Hello, thank you for joining us today. My name is Becky Sulkin. I will be your co-presenter today for this session titled Highway to Help, New On-Ramps for Recovery from Addiction. If you think you found yourself in the wrong session, just go back to the conference homepage tab and click on the title that you wanted to attend. A reminder that the conference sessions will be available for viewing for 60 days after the conference, with a link sent to you after the conference. Please do keep yourself muted until the appropriate time when asked by myself or my co-presenter. We'll be taking questions at the end of the session, but in the meantime, you can post questions using the chat feature. The icon can be found at the bottom of your Zoom screen. Although we may not be able to get to all the questions, we will do our best to try to summarize and respond to as many questions as possible, either in the chat or during the Q&A at the end of the session. We recommend using the side-by-side speaker view with the buttons in the upper right-hand side of your Zoom screen. For technical issues with the conference, click on the email button on the conference homepage to submit questions that will be answered in real time. I'm honored to be speaking today. My name is Becky Sulkin. I'm a licensed independent clinical social worker and the program manager of Jewish Community Addiction Services at JFCS Minneapolis. I've overseen the design and implementation of multiple recovery-focused initiatives of Jewish Community Addiction Services, including professional development, resource navigation, peer recovery support, and community education. I'm trained in treatment coordination for substance use disorder and peer recovery coaching. I have professional experience as a mental health case manager and a crisis intervention clinician. I also manage the Jewish Youth Mentoring Program at JFCS Minneapolis. I'm joined today by Lorna Hunt Ellison. Lorna is duly licensed as a mental health professional and alcohol and drug counselor in the state of Minnesota with nearly 10 years experience in a variety of settings. In the healthcare field, she served as a consultant to medical providers at Hennepin Healthcare Systems, formerly HCMC, providing assessment, intervention, and assistance in discharge planning for patients admitted to hospital with substance use disorder diagnoses involved. She has also managed both the inpatient and outpatient addiction services programs at St. Joseph's Hospital. Lorna has served as a member of Hennepin County Diversion Courts, providing treatment alternatives to incarceration for eligible Hennepin County residents involved in the criminal justice system. She was the substance use disorder assessor and consultant to multidisciplinary teams in the drug, DWI, and Holmes courts. She is currently employed by Hennepin County Human Services as a social worker conducting clinical reviews and funding authorizations in the Addiction and Recovery Services Unit. Thank you for joining us, Lorna, and I'll have you take it away.
Thank you so much for that introduction. It's my pleasure, and it too is an honor that you've asked me to collaborate with you today. So there's a lot we need to go over, and you know, our topic is those new ramps of the highway to help. But I thought we would be remiss if we didn't go back just a little bit, take a step back and look at, well, what are we talking about? What is addiction? How did we arrive here? So the nerd in me will want to talk about the historical perspective, how we have arrived at some of the current approaches to recovery, how we have been accessing treatment in the state of Minnesota for the last, it's nearly 35, nearly 40 years, and how a seismic change through substance use disorder reform that was passed through the legislature in the state of Minnesota in 2017, how that truly has radically reformed that Rule 25 process. And then we'll wrap up with some other recovery supports and resources. So when we diagnosed, we looked at 11 different particular symptoms that could be present. We like to kind of group them into 4 different buckets, if you will. The first being the physiological, or the things that happen to your body when any substance is used to excess, or that there will then be harm around the use. Loss of control, if you've ever known someone or you yourself that you just were using far longer than you ever intended to. Have you ever tried to cut down or control your use? Those are all particular clues that we will look for when we have a conversation, when we ask questions. when diagnosing. Risky use. Have there been times when you knew it was harming you, but you continued to use? Or were there situations when it was physically hazardous? And then for alcohol's use today, a hazardous situation is I do get behind a wheel. Now, we're not looking for that there was a charge of driving while impaired or driving while intoxicated, but that we all know that to be a hazardous situation if you attempt to drive after you have imbibed way too much. And then there are the very common ones, the ones that we probably are more familiar with, those social problems. Hey, I used to love playing volleyball in a community program. I haven't played in 2 years. Well, why? Well, I'm often hungover Saturday mornings when the community group would play volleyball. Other activities, I used to love spending time with my children. I no longer have the patience to do that. Those kind of things. I say I'm going to go to work and I don't go to work. And then just, you know, people are writing me off. People I don't get invited to those parties anymore. So that would be another thing. And it's there a series of questions through an assessment. We're able to collect this information, and it remains the gold standard assessing is that we want the clients reporting, and hopefully a truthful report, which it actually is for the majority of the situations that we see. People are quite frank and forthcoming when asked questions around their use. Now, there are other people who chime in and with good reason. And you're going to, and part of reform is moving toward adopting much of what the American Society of Addiction Medicine, commonly known as ASAM. So we love our acronyms in this field, probably not unlike most fields, but it defines addiction as a primary chronic disease. And I'm so glad, Becky, that like you embolden this, you underline it. We should have neon that it's a chronic disease. What I mean by that is we do not have a cure, right? And it is a disease of brain reward. So going on your brain, motivation, memory, and related circuitry. So it's all up here, what's going on. But for how long did people, well, still today, if she would only just stop drinking. He's a really good father if he would only, if he loved me, he would stop drinking. Well, no, not if the brain has hijacked, the brain circuitry has been hijacked through continued use of the substance. The chronic, and so it is a disease. Dysfunction in those circuits lead to characteristic biological, psychological, social, spiritual manifestation, doing things that you swore you would never do. So it's not dissimilar to what the DSM is looking for, but I just love how the docs are on board. This is a chronic disease. Like all chronic diseases, addiction often involves cycles of relapse and remission. And while that is a quote, they use the word relapse. I'm just going to do a little commercial for my own personal preference. I'm big on language and trying to destigmatize language around our field, that a relapse, I don't know, it has a negative connotation, perhaps. It does for me. I much prefer the recurrence of use. So hear that it's not a straight line, that there could be cycles. Historically, back to the 1700s, Dr. Benjamin Rush, signer of the Declaration of Independence, a physician who lived in Philadelphia. He was one of the really first that, wait a minute, let's look at what alcohol does to the mind and to the body. After Dr. after Benjamin Rush, we move into kind of that era of the temperance movement, which is often based in religion. And it was just saying, nope, we need to just not have any alcohol at all, right? How successful do we think that happened, right? Not too much of a success. But it was around this time, well, it didn't work, right? And we still had lots of people who were suffering from alcohol use disorder. Again, not known as alcohol use disorder at the time, but it was around the time when prohibition was over, but you still have the problem. So it didn't work, problem's still there. Well, 1935 is, you know, I think many are familiar with the story of the founding of Alcoholics Anonymous, which becomes very important as the influential movement and really the only movement. There were successes, not 100% success, but there were success stories, and I will never, ever take anything away from the power of a 12-step recovery program for those who find comfort and help and healing in a 12-step recovery. It has its limitations, but it has its value. And in fact, he wasn't a physician, he was a physiologist. What was his name? Elvin or something, I don't know. But he was known as Bunky, was his nickname, Jelinek. And he, in fact, while this kind of like keeps evolving, you know, refining what Dr. Rush first talked about, that, you know, there's something going on with the mind and the body. He went as far as to, like, for the first to introduce that it was a disease. And he called it the disease of alcoholism. And it was very interesting. He was highly influenced to the extent that one of his first big studies was paid for by 2 early members of Alcoholics Anonymous. His research was mostly out of that movement, and it really didn't address treatment or professional treatment, because AA is a recovery support group, but not professional treatment. So about in the 70s, we started saying, well, wait a minute, we should be looking at the behaviors around alcohol use, right? And let's look at patterns and behaviors and use. That behavioral model that we start talking about changing your behaviors to change the use patterns, that was introduced in the 70s and became the basis of so many of the treatment programs that we're familiar with. Much of what was introduced and developed during the time is still relevant and still influential. Recovery focuses on behavioral changes that promote improvement, and this is where we're at today. This is kind of like moving us to where we're at today. Any kind of recovery that focuses on behavioral changes that promote our improvement and well-being, overall functioning, that's where we're at today. Okay, so often for many, licensed substance use disorder treatment programs may be the starting point. Again, may, not is, may be a starting point. And when you're seeking help, it's going to begin with an assessment. And for so long, 1986 is when this juggernaut began, which is actually, don't get me wrong, we are blessed in the state of Minnesota that we all live in the state which is devoted, I think the last numbers, I think $160 million a year that we devote to those who cannot afford to go to treatment. That's pretty radical when you look at other states and how they approach it. So I'm proud of Minnesota for that. And when those funds were needed to be distributed, it begins with what was just lovingly known as the Rule 25. People would walk around saying, I got to go get a Rule 25 at the blah, blah assessment site. And in fact, it was the kickoff point of substance use reform. I mean, there's been discussion long before even it finally passed in 2017, but it began, that Rule 25 process just was not sustainable. But by definition, it was the process by which there was assessment. We determined eligibility, we diagnosed, we made decisions. When I say we, that's what I do for a living, or I did for a living for a very long time, where counties made decisions ultimately of where a person would go to treatment when they needed to access the state funds. I think we can move on.
How long did that take for folks to get into treatment, having to go through this Rule 25 process, and what was involved in the process?
While the Rule 25 process was a terrific thing, right? It was the way that we delivered things. It was not without its flaws. The most glaring example, well, forget the fact that the whole assessment process was 18 pages, not necessarily needed all 18 pages. But the other thing too is I wake up one morning, it's like, oh my gosh, I need help. I call up a treatment center and say, can I come in to get an assessment? By law, that treatment program had X amount of days, 20 days. When I say X amount of days, it's like, I'm almost embarrassed to tell you that the law was written that it was allowable for that program to schedule somebody 20 days out and it not be a violation of law, which almost sounds criminal to me because, when people are asking for help, it's got to be available. The other thing that happened is once the assessment was a face-to-face interview was conducted, then there were 10 more days on the back end for that assessor to finish up the assessment and to send it into the county or tribal authority. And I say we because, I work for Hennepin County doing this. We had 10 more days before it was allowed by law to make a decision of where ultimately that client would be allowed to go to treatment. That's not right.
So from the time someone decides they need treatment to the time that they are able to access it, or at least be told where to go to access it, by law, 30 days, a whole month was allowed?
Isn't that crazy? It's almost, anyway, I mean, it should be obvious to all of us how untenable that was. There we go. But the fact that, as we talked about already a little bit, that ultimately the assessor would make the recommended level of care, but then it would come into us or the county unit who would be doing the clinical review. And sometimes that recommendation that the assessor would not be sanctioned, we would change it. So the process that we've been talking about, the Rule 25 process, that again is in its evolution to be sunsetted, I think is the term that our Department of Human Services are using. It had to be a face-to-face interview, which I think is a wonderful idea, by a qualified assessor. Not just anyone could do an assessment. You had to be qualified. And we used a Rule 25 tool and something called the Minnesota Matrix. It basically kind of talked about what you've already introduced, Becky, that when someone needs a higher level of care from what they're describing in terms of where their life is today or has been over the last 12 months, well, that level of risk that they're describing to you of how their life is today needed to be met with a level of care that was commensurate, right? And that's basically where sometimes there would be a disconnect, but the assessor would make that recommended care, come into the placement authority, and that if agreed upon, funding would be put in place for folks who needed to access those public funds. So that was kind of the way we did it for nearly I keep wanting to say nearly 40 years, probably 35 years.
Mhm.
And this hasn't changed, although the reform did address some things. If you are an underserved person in the state of Minnesota, specifically in the county, in Hennepin County, and you are income eligible. So take a peek at the one column. What FPG is federal poverty guidelines. So we're talking about those who cannot afford to pay for it out of pocket. If you are a household of one, that's your HHS household size, and you make less than $17,130 this fiscal year, you're going to be able to access the funds. You also, and this is like little known out there, is that you could be covered under a commercial plan also, but your commercial plan is not a good one. And you have tremendous copays or out-of-pocket expenses or unmet deductibles or all those clunky, cumbersome things that could keep people from accessing help, right? Well, the state of Minnesota generously says that, well, we'll let you access the funds for that differential. We'll ask your insurance company to pay first, but anything that you're left with and you are income eligible, so take a look at that chart again. If you are of low income or underserved, then in fact that like the state will pay for that differential. But we've already touched on how some of that wasn't working, right? We talked about the fact that the assessment was 18 pages long, that we didn't need to ask all that we asked. It took too long. It also focused on episodic responses for particular needs. Remember we talked about that medical model where people like will have periods of where they'll be in periods of wellness, but then they'll go kind of awry and I've had a bad couple of months. I need to tweak it a little bit. This reform was able to address the fact that help and help around substance use disorder has arrows on both ends. There'll be
It's a continuum.
Absolutely, that you can move back and forth. Right, I need my visual now. If we were in person, I'd be like drawing somewhere that, there'll be times when, no, I've got it together. I don't need, maybe I need just like a once a month check-in at my old treatment, some aftercare type programming, or I need to meet with my peer specialist, something minimal. Or I've been off the rails for the last 6 months, I need help. And that's where the arrow works both ways, but that it's chronic and it's lifelong, just like anything else we've talked about. We talked about diabetes, like rheumatoid arthritis, all the things where if you can change some of your behaviors to improve your chronic condition, your chronic disease, you may need some help, just right? Like sometimes diabetes requires medication, sometimes it just needs a little more exercise, whatever it is. But in fact, start thinking about substance use care along the same way we think about some of our other medical conditions. Okay, so reform was passed in 2017, took a little bit of time for DHS to implement the strategy. But out of reform, the reform legislation that passed in 2017, the most notable being we replaced the Rule 25 assessment tool with something called the comprehensive assessment. Sounds very similar, but actually it's not. We got rid of some superfluous questions. We didn't need to delay the client. One of the things that Rule 25 would do is demand, while we know that the gold standard of assessment is self-report, we demanded 2 collateral sources, that someone who knew you well would confirm what you just reported to me. What doctor does that when you go in to see your doctor for your diabetes care? Well, I need to talk to your daughter and your husband first to ensure what you just told me was correct. Anyway, so the comprehensive assessment got pared down to a more manageable, more focused tool, and they developed something called direct access. Remember that 30-day time horizon we talked about? Gone. And in fact, direct access is just an easier way to access treatment. And what it allows for is they can go directly to a treatment provider and say, I would like to be assessed today, and I'm pretty comfortable and confident that I want to enter your outpatient programming. Can I do that today? Direct access says, sure you can. Now, there's some caveats to that, which were what we've already talked about. Is the person income eligible? Do you have health insurance through an employer, through a parent? Will it fully cover the costs involved? Those kinds of things that are screened. But for the most part, people can start care that day, providing they're appropriate for the program and there's an opening at the program. How revolutionary is that? No 30-day, I know, right? No 30-day wait. I love it. I really love it. Now, when they also said that, remember I talked about how the assessor would make a recommendation for level of care, then it came into the placement authority to either confirm that recommendation or change it. Not anymore. That person who comes in for assessment, they can fully report that their life is totally off the rails, but they still, I want to begin by a 2-day-a-week outpatient treatment program. Direct access says, okay, if that's what you're willing to do, even though as an assessor may not agree, you get to direct your care now. Wow, right? It just gives greater latitude for that client to say, no, I want to go here. That was not enjoyed under the Rule 25 process. It really wasn't. We added individuals who were eligible to be vendors. Now, there's a process. You have to register with the state to be one of those vendors.
I think of it like a funnel where previously everything was getting narrowed into the county and that slowed down access. Now we have multiple pathways, new on-ramps.
What did we do? We turned the funnel upside down and we broadened it, right? There you go. Good. I like it. I like it. Okay, next slide. What it added to, believe it or not, if you needed to have medically supervised withdrawal management care, which that's a level of care, it's a type of treatment, it's acute, it's not long, it makes sure people are safe when they're coming off of a substance through medical supervision. It was never paid for out of any of the funds for Rule 25 funds. It got added in at substance use disorder. So as a result, there are now new withdrawal management centers opening, which was the hope when they added it in as a reimbursable support. Peer recovery support services that I know you know so well. It was it was always being provided at programs, but the person's time was never reimbursed.
This is such a huge, exciting change from my perspective. One of the things that I think we learned from 12-step programs and other peer recovery groups is that there is such value to that shared lived experience, and that peers can really show what recovery can look like and help guide folks who are new to recovery on their own path. So that's one of the things that has stuck around, I think, from AA. And the fact that we are now assigning a monetary value and compensating those people for the experience and insight that they bring is such a huge step in the right direction.
Absolutely. And and they're professionals. They are trained. There's training involved. There is a level of, there's a different set of parameters that checklists.
There's a credentialing system. Yes, there's the education piece, the exam, continuing education. So it's, it's regulated.
Absolutely. And so very important. And in concert with a licensed alcohol and drug counselor, as a team approach, it's just one more support service that's there that wasn't there before. They've been there, but not reimbursable. That's so important. Because if you're a program working on small margins, I'd love to have 6 peer recovery specialists, but I can't afford it.
Right.
Well, now maybe you can. Also, and this is really important, treatment coordination. When women go to treatment and there would be your counselor helping you find sober housing or helping you address your unattended dental care that hadn't been, whatever it is, finding a therapist outside in the community when you left treatment, all of those kinds of assistance was just done on a counselor's own time. Now, any of that time is billable, is reimbursable as a billable service provided. Wonderful. It's the right way to go. It was
so
happening.
Holistic.
It was happening in treatment programs, but now being recognized as having the value that it does.
So we have reached, sort of the conclusion. Lorna, I am just always so excited to hear your perspective on recovery, and you're just so knowledgeable about substance use disorder reform. I do want to highlight some of these resources for folks that are available. There will be, I believe, links to these documents and websites available on the conference homepage or through the conference homepage. Certainly a little personal plug for Jewish Community Addiction Services here at JFCS. Be sure to visit our Facebook page where we share resources and insight and events and opportunities. I want to call attention to Fast Tracker, which is a fantastic website that we have in Minnesota for both mental health treatment and substance use disorder treatment that you can pick out certain criteria that you're looking at, filter by that, and in many cases see real-time availability of those services. For more information on substance use disorder reform, I would direct you to the Minnesota Department of Human Services. Also check out Hennepin County or Ramsey County Addiction and Recovery or Chemical Health Services. As Lorna mentioned, recovery-oriented language is very important to how we understand this as a chronic disease and combat stigma. So be sure to check out that recovery-oriented language guide. And the eligibility guidelines for that behavioral health fund for funding to treatment is linked right there at the bottom. So again, thank you, Lorna, for sharing your expertise and your time. And I think we'll open up to some questions. Thank you, everyone. We are glad that you all joined us today. Happy to answer any questions that you might have about the presentation. We can go a little bit in depth. We've got some time here to chat. So feel free to unmute yourself if you do have a question. Otherwise, Lorna and I do have some additional information that we can share, but I'd love to give folks a chance to ask any questions. And Allied, we can probably stop screen sharing on that one. All right, well, Lorna, again, thank you so much for being with us and sharing all of your expertise. What do you really hope that people take away from this presentation?
That help and recovery exist, very much so. And we're all blessed to live in a state that does devote the resources that we do to it. And help is there. Just ask for it.
Absolutely. I echo that. And, we recognize that figuring out how to navigate this highway to help can be really challenging. There's no Google Maps for this. You may know where you're trying to go, but how to get there can be a really big question. So that is why, I thought it was important to bring this material to this conference so that we could explain to folks that we're trying to make a little bit more of a direct route, that direct access to treatment. We are trying to just eliminate barriers and promote holistic recovery for folks. And I do want to emphasize, what recovery can look like. So I will share here for a moment, because I think a lot of people, let me see. I think a lot of people think about recovery in terms of sobriety or abstinence.
Mm-hmm.
And it's important to recognize that there are so many other things that that are part of recovery, of living one's best life, in spite of or despite substance use disorders. So Lorna, do you want to speak to this at all, and SAMHSA's working definition of recovery?
I love how the approach is that it is so multifaceted. The most important one there, which was something that may not have always been there, but maybe the two. It's a respectful, person-driven approach now. Someone gets to define what recovery looks like to them, not what the counselor says, not what the assessor says, not what parents say. But the hope is that it's grounded in improving wellness on a day-to-day basis. But what their recovery looks like may not be what a traditionally thought of definition of wellness is or recovery. And that's, for me, is the most important. Every one of those ones are there. It's so very important. The cultural aspect of this. And the fact that I talked a lot about how the assessment process begins that ramp to help to getting on the highway. But no assessment would be complete unless you were really capturing what is it about the person that defines them with their strengths. So that's a jumping off point when they do get to treatment. It's like, well, let's build upon that. I just love the fact that that wheel is just wonderful.
Right. And I know you'd like to talk about how this wheel feeds into this idea of recovery capital, the resources that we have that promote recovery for us in an ongoing way. So, having a supportive family is recovery capital. Having sober activities to go to, recovery capital, having a job. But really it's all those strengths, those things that we that are inherent within us that we're identifying and really homing in on, so that we are using those to our advantage instead of this one size fits all approach. And of course have to echo and agree with what you're saying about a person-driven process. And how lacking that was in the Rule 25 model. I think for a lot of folks, a barrier to initiating recovery has been if they go to a Rule 25 assessment and are told you need inpatient residential treatment for 60 plus days, that's so disruptive to their lives. We know there are people out there who have substance use disorders and are, parents and have jobs and have other caregiving responsibilities that they can't just abandon. And so they may say, I'd really prefer to do intensive outpatient, 3 days a week. And also, go to SMART recovery meetings or 12-step meetings or, have a peer recovery coach for that one-on-one support. So it's really, instead of fitting square pegs into round holes, just fitting the services to the people.
Oh, sure. The worst is having to have the discussion with the person who says, I just worked on getting housing. I will lose my housing if I go to treatment for 60 or 90 days. It's like, who faced with that choice, what will happen? Which there have been improvements around that also, but there's all sorts of potential barriers that we're working on every day eliminating.
Absolutely. And how do you think, I know this is sort of like, a fastball question. You weren't expecting this one maybe, but how do you think the COVID-19 pandemic is going to impact people trying to access treatment? How has it already impacted it? And moving forward, knowing that this SUD reform is going to be fully implemented by the middle of next year, what do you expect us to be looking at in terms of barriers and opportunities?
Excellent question. We've already seen and are feeling the effects of, people still, if anything, people needed more help because of the pandemic. But face-to-face was a problem. We weren't able to meet face-to-face with one another, especially in the early days, before we really understood and before vaccines. Telehealth, and now it's not unique to substance use disorder, other aspects of the medical profession adjusted as well, but telehealth was just wonderful. Mm-hmm. The transition, it took people a little bit of time figuring out how to sign documents electronically, but when document signatures were required, but the fact that same assessment that the law said had to be conducted face-to-face, well, face-to-face can be virtual.
Yeah.
And that's going to stay around. So that's a wonderful thing. Now, of course, the downside of the pandemic, to speak to specific to substance use disorder, there was a tremendous increase in use. We saw it with overdose among certainly many substances particularly with the opioids. We have more overdose, and it's not only opioids, it would have been within stimulant use disorder also with methamphetamine, but
the demand is going to be so high, perhaps.
Absolutely.
With that, I would just add, something that we didn't get to cover in this presentation, but that, I hope people are aware of, is the availability of naloxone, commonly known as Narcan, which is an anti-overdose for opioids specifically, medication that is available for free to people. So there are resources available to that. First of all, many pharmacies have dispensing policies, and in fact, the Department of Human Services, I believe, has a program that allows pharmacists to prescribe and dispense Narcan, independently, just to get it into people's hands to try and prevent overdose. So that's something that, from a real harm reduction perspective, that we want people to be aware of, that check with your insurance. Your insurance may cover it. If it doesn't, the Steve Rumler Hope Network has free access points where they will train you on how to use Narcan. I believe the ones that they distribute are the intramuscular. So it's going to be a vial and a needle, syringe. But they will train you even digitally how to use it and get it into your hands. And I think that that's so important. I wish everybody were walking around with that. Just in case you come across someone who is having an overdose, because we can save lives. And, so if you have any questions about how to access that, feel free to, drop them in the chat or unmute. But, I think in terms of recovery, the first thing is always people have to be alive to get into recovery. And so to me, that is a ramp to this highway to help, is that we have to be providing that.
I carry my kit, and I have a good friend who was appalled to learn that the airline industry didn't have them on flights. And he had worked, there's a couple of airlines that he got on board that they now carry Narcan kits on each and every flight. So, I mean, just thinking about the times when would we need it? Who thinks about it on an airplane? But
wow, that's alarming to think about, how easy it would be for somebody to overdose on an airplane. So kudos to your friend for that. Really, really awesome. Goodness, I had a question related to that and it's slipping my mind now. But just generally, what are some opportunities? Oh, I remember now. So, we made a joke that I think was cut from the final version about Minnesota being the land of 10,000 treatment centers. We know people come to Minnesota from out of state to get treatment. How does this SUD reform apply to out of state residents, if at all?
Well, that's a good question. And that's, while it's a generous state, Minnesota, it is not without its limited resources, just like any other. But I must say that our requirements are a little more relaxed than others. People can come here to go to treatment. They need to intend to stay here. That's so I hesitate offering that, because truly, I mean, one doesn't necessarily know that they intend to stay here, but that is the criteria. That's the important one, that you have to be a resident, right? And you can be a resident, you can establish residency within the first 24 hours and intend to stay here. So we in Hennepin County, there are other counties out there, and this is something that still is left for a county decision, but we've been generous. We don't put people asking for help through that many hoops. When we can, we help anyone who asks. Let's put it that way.
Absolutely. Yeah. And, we're not trying to create a sort of recovery tourism industry here. But what I think is really great, and again, that SUD reform speaks to, is that there are other supports in place for ongoing recovery, that it's not just treatment, it's the recovery supports beyond that, the peer recovery support services, the treatment coordination. And so we can say confidently to people who maybe are not sure if they plan to stay here or not, we can support you after treatment. With that, want to give some shout outs to, some of my favorite recovery organizations in the area, to Recovery Cafe Frogtown that just had their grand opening yesterday in the Frogtown neighborhood of St. Paul, doing just some really phenomenal things to support people in the community in finding and maintaining recovery through vocational support, social support, culturally appropriate support. So, shout out to them. Minnesota Recovery Connection is just a phenomenal organization that provides both education and connection to resources and peer recovery supports. Lorna, others that you really like?
While I've offered its limitation about the 12-step facilitated groups, all the anonymous programs, the Alcoholics Anonymous, Narcotics Anonymous, Overeaters Anonymous, all of those programs, they're wonderful support. They're not for everybody. And that I do always offer that if it's not your cup of tea, that's fine. Let's find you another one. Find one that's more based in CBT, which would be Smart Recovery or any other, but any kind of group or organization that helps people adjust to a life without drugs and alcohol is going to be worthy. It can be your faith group. It could be at your church or synagogue. It's just something that's going to put value into your life and meaning, when in fact your life and meaning was always derived from pursuit of drugs or alcohol.
Yeah. I also want to highlight, given that this conference is hosted by the Twin Cities Jewish community, that one of the positive things that has come out of the pandemic is the emergence of a national and even international Jewish recovery movement. And so if anyone, listening, or, folks who may view this in the future, if you're interested in finding out more about online meetings, events, resources that are specifically Jewish in nature for folks in recovery, feel free to contact Jewish Community Addiction Services. We're happy to help get you connected because we do often hear that a lot of these meetings take place in church basements, in Christian spaces. And I've had someone tell me, the church ladies in my group are nice, but they're church ladies. And so we want to continue to build a Jewish community that is really supportive of recovery and working to eradicate stigma around addiction.
And there's another area that I might just throw a little plug in. Young people in recovery, it's happening. We have a wonderful sober high school program called Pease Academy.
Yes.
And then I have personal firsthand knowledge with my daughter. We have a recovery, a collegiate recovery program that's at Augsburg College called Step Up. So I'm proud to share that I have a daughter who's a graduate of the Step Up program, which is how difficult it can be for maybe a young person who might be in college, how hard it is to imagine going through college, not having their whole community and support group to be outside of that which was around drugs and alcohol. Instead, it was a recovery group and wonderful connection. And they lived together and they studied together. It was really fabulous. It's one of the first in the country. I think the very first one was in New Jersey, but
so cool.
We're lucky there. Yeah.
Love that. And it's a great reminder that, it doesn't necessarily take a lifetime of substance use for someone to benefit from recovery. Anybody can enter recovery at any point. It's never too early. It's never too late. So I'm aware of the time. I know we've got about 5 minutes left in this session. Again, we invite anyone that has questions, comments, resources to share. Feel free to unmute or raise your hand. Otherwise Lorna and I will keep kibitzing. We're happy to talk. We're happy to talk recovery all day. Lorna, what are some opportunities or perhaps needs that you see in terms of continuous improvement of the system, the substance use disorder treatment system, and how can people get involved?
Well, the first is what needs to keep happening. We have to keep the focus on just truly allowing people to define recovery for themselves. And I just can't say that enough as a professional, because I come up against it with colleagues that, nope, it's got to be abstinence. It's got to be abstinence from all substances. And it's like, well, maybe not. and how hubristic of us to know what's best for a person. So the more we do about that, the more we as a field, we as professionals respect the autonomy, the agency of one to make their own decision of what their recovery looks like. I think the better for everybody in our work. I really do.
Mm-hmm.
I truly do. How can people get involved? Attending things like this to go through that, the language of recovery, because I think I tucked that one in there as a resource.
Yes.
But there's just, just even the fact that, like I think I mentioned it in the slides, I mentioned it a lot, but it's like, it's not a relapse. They used again. Okay. It's
right.
I mean, it's such a condemnation when it's like a relapse. They had a dirty UA. It's no, the test for the test for whatever was positive. It's not a dirty UA.
Right. Absolutely. Huge is just combating stigma using recovery-oriented language. And helping introduce that to other people. Love that you shared that. Again, everyone, I did put in the chat that you can find all those resources that we listed on the conference homepage. There's a tab called Session Handouts. So just scroll to the bottom. I think ours is the last one. It's there along with the slides from this presentation, probably actually some additional slides. I think you got the longer version in the handouts. So, feel free to take a look, and we do hope that you will all take these messages, what you've learned, back into your communities, into your work, into your life, and help promote recovery and remind people that recovery is not just happening, recovery is probable. So with that, we'll go ahead and wrap up. Please, if you have a moment, fill out the session evaluation on the homepage. The conference organizers really take to heart all the feedback that you give so that they can shape next year's conference using that feedback to make sure that it's all information and sessions that are really valuable and useful to you.